In the past few decades, U.S. healthcare has undergone a profound shift. Although the profit motive has always existed in medicine, the control of large profit-seeking conglomerates over the people and entities engaged in healthcare delivery has intensified and spread throughout the healthcare system. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Erin Fuse Brown, a professor of health services, policy, and practice at the Brown University School of Public Health and a member of the journal's Perspective Advisory Board. Professor Fuse Brown has written a perspective article introducing the concept of healthcare corporatization as part of the journal's new series on the corporatization of U.S. healthcare. Professor Fuse Brown, how do you define corporatization in the healthcare industry, and what have been the manifestations of this trend toward increased corporatization?
The definition that I came up with for corporatization really draws on a long tradition developed by and identified by Paul Starr in his iconic work, The Social Transformation of American Healthcare. And in that, Paul Starr talks about this rise of integration, consolidation, and corporate consolidation as sort of the future trend that was facing the U.S. healthcare system when he wrote that work back in 1982. So I offer an updated definition of corporatization that reflects the trend that Paul Starr identified so many decades ago. And so the term corporatization now refers to the general trend throughout the healthcare industry toward higher levels of integrated control by consolidated profit-seeking enterprises.
So you say in your perspective article that a key element of that definition is the elevation of profit generation as the primary goal of the healthcare enterprise. In what ways has corporatization led to a prioritization of revenue over patient welfare?
Yeah, so one of the main concepts of corporatization is the concept of shareholder primacy. So these corporate forms have been long known to have a primary duty, which is to maximize shareholder profits. And this was an idea popularized by neoliberal economists. Milton Friedman famously advanced this concept of shareholder primacy. And so when you have a primary duty to your corporate shareholders to maximize their profits, that sometimes comes into direct conflict with the other stakeholder interests that healthcare institutions might have, duties to their patients, to their workers, to their community. And so what we see is both in the context of hospital systems, particularly those that are converting from nonprofit to for-profit ownership, but also as we see physician practices getting bought up or controlled by larger and larger corporate entities, we see this tension come into direct conflict where the pressure to maximize profits or increase revenue generation for the shareholders or the investors comes into conflict with providing the best patient care, providing the level of workforce stability, staffing levels, and the like to ensure that the community is well served by that institution.
So a second key element of corporatization that you mentioned is consolidation. What types of horizontal and vertical consolidation have occurred in various sectors of the healthcare industry?
Consolidation is another, as you mentioned, another key element of this concept of corporatization. It's not just that we're shifting from a nonprofit or a patient-centered focus to a profit-seeking focus. It's also that this focus is being controlled by larger and larger consolidated entities. And these entities are consolidating what we call horizontally, so the same types of services being combined into one firm, consider two hospitals in the same market, combining into one health system. But also what we see is vertical consolidation. And so we see vertical consolidation by health insurance companies buying up physician practices, PBMs, pharmacies, and other types of up and down the supply chain of the healthcare industry. And so both forms of consolidation have increased dramatically in the past 40, 50 years, such that we see large health systems dominate most markets. And we see the rise of entities like United Healthcare that are really sort of the biggest players in all of these multiple markets of the healthcare system, from the largest employer of physicians to one of the big three PBMs to the biggest health insurance company. And so this type of consolidation not only increases market power, but it also does have a different effect of insulating these large entities from typical reputational market discipline if they were to compete in just one individual market. And the sheer size of them makes them politically insulated, reputationally insulated, and they become so big that they are almost too big to fail, which means that the entity enjoys a type of political and governmental insulation. If they were to be threatened by, say, a cyber attack or financial distress, there's a lot of pressure to prop them up, essentially, and not let them fail.
And then How has all of this affected the cost and the quality of healthcare in this country?
What we have seen is that the rise of, say, examples of corporatization like private equity investment in hospitals and physician practices, but also this sort of insurer or other types of corporate consolidation, it has largely, almost certainly increased healthcare prices. So we know that consolidation is the largest driver of rising healthcare prices in the commercial insurance market, but also just in general, the ability of a large conglomerate or a large dominant player to command very high prices because you basically need them to participate in your insurance network, or you need to do business with the largest entity offering a product in order to serve the patients or the customers or the consumers that you are serving. So we know that corporatization has increased healthcare prices, but it has also had the effect of, in some spaces, reducing access and quality, or at least having mixed impacts on healthcare access and quality. And one of the ways we see this manifesting is when, for example, a large health system becomes acquired by private equity, like the Steward Health System, or more recently, the Prospect Healthcare System. And then it sort of undertakes certain tactics to maximize revenues, such as reducing staffing levels, selling out the real estate from underneath the hospitals. And that leaves the hospital in a financially precarious sort of downward spiral. And so we see the threats to hospital closures, communities losing their community hospitals from these types of tactics, which are really pursued, again, not with the best interests of the community or the patient's health in mind, but with the idea of increasing profits.
And then what has corporatization meant for the practice of medicine, including the physician-patient relationship?
Corporatization has also had, what we're seeing is an erosion of the physician-patient relationship. It's sort of inserting between the physician's decision-making for what is in the best interest of their patients, which is the physician's primary fiduciary and professional duty, inserting into that calculus this pressure to increase profits for a management company or a financial investor. So, for example, this might require physicians to see more patients in a shorter period of time, or we see there's a substitution of physicians with advanced practice providers, which may not in itself be a bad thing, but it's a way to sort of do more with less, right? We see a lot of this sort of profit seeking, pressure on physicians to engage in coding practices that maximize revenue to the parent company, but really sort of feels like administrative box checking for the physician. And so I think over time, we see that physicians have been reporting high levels of whether it's burnout, what's called a moral crisis, loss of professionalism, and a loss of autonomy, really, the ability to sort of practice medicine in the way they think is best for their patients, because there is this pressure to maximize profit sort of always looming in terms of their compensation, their schedules, every aspect of the work. And so as their morale is eroded, we see that that is maybe contributing to a shortage of physicians, particularly primary care physicians and others who are either exiting the profession or trying to find another way out.
Finally, you say in your article that confronting corporatization may require a fundamental reorientation of the industrial organization of our health system. What would that look like?
I don't know if we have a clear sense of exactly how this would look, but I think that one thing that is clear is that if we continue just to kind of keep on going and sort of let the big entities get bigger and those with capital resources to buy up large swaths of the healthcare system, we're only going to see this sort of corporatization and this pressure and these conflicts between profit seeking and patient care increase. So what would it take to reorient the healthcare system might entail structural separation or breaking up some of these big conglomerates, particularly those that are in a fundamentally conflicted position of both buying healthcare, for example, being insurance companies, and also supplying healthcare, being a physician or being a pharmacy. So we see some bills being introduced or passed that would separate, say, if you own a PBM, you can't also own a pharmacy. But similar concepts could be applied across the market to, again, sort of eliminate some of these large corporate conflicts of interest. We could also imagine more policies to standardize either prices or do other things on the rate side to limit the ability of monopoly or large conglomerate entities to use their market power to abuse competition or preference their own related parties over independent providers. We also know that there's a real demand for capital, and alternative sources of capital are needed to finance the increasing cost of technology. The health information technology is extremely expensive, and so we know that a lot of, say, physicians are unable to continue an independent practice because they need the support of a large entity in order to buy an electronic health record system. But we fundamentally can think about larger concepts of rules of governance. Healthcare entities might be subject to more oversight, as we see lots of states are starting to provide more oversight over healthcare, hospital entities and other types of licensed entities that make it harder for private equity companies, for example, to do what they have been doing, which is to sell the real estate or to strip some of the assets from that company and to limit the amount of debt that can be taken on by those hospital systems. So we can see that there would be lots of different levers to pull, but a lot of it is really just rethinking about who and what does the healthcare system serve? Is it there for the investor or is it there for the community and the patient? And I think that we're getting to a point, a boiling point really, where the public is starting to sense that the healthcare system is not really there to provide them healthcare. And that's creating a deep sense of unease, anger, frustration, and to those who work in the profession, I think there's a loss of a sense of a calling, that this is something that they could make a career out of and serve a community and serve patients. And so I think that there is a lot of opportunity and hopefully momentum behind asking some really hard questions about how we want the healthcare system to look in the next 40 years.
Thank you, Professor Fuse Brown.